Hi, good morning, good afternoon, and good evening, wherever you are. My name is Joe Hawayek, and on behalf of the Partners in Digital Health, I am delighted to welcome you to the 5th annual Converge to Accelerate Symposium. This is 2021 Symposium. In this session, we are welcoming Susy Postal. Susy Postal is the Chief Health Informatics Officer at the Indian Health Service. She's going to talk to us about the Indian Health Service and how they improved access to care through telehealth. I shall ask you, Susy, hello, how are you? And please tell us a little bit about yourself and the Indian Health Service. Introduce us to your work over there.
Hi, Joe. Thank you very much for this opportunity to present and to talk with you about the great work taking place at the Indian Health Service. The Indian Health Service is part of the Department of Health and Human Services. It's one of the agencies. We support 2.6 million Native American and Alaska Native patients to provide healthcare. We have 12 areas within the United States that it's 37 states that we support the healthcare of the population, and we have 24 hospitals, we have health centers, and more. We are the federal aspect of the healthcare. There is also tribal and urban as well, and I will be speaking mainly about the federal support to improve healthcare through through telehealth. My role as the Chief Health Informatics Officer is I help to lead quality initiatives, bridging medicine with technology. The important thing to note is that we expanded telehealth in 2020, and you'll hear more about that. So to help improve care, to help support our healthcare providers, to help support our patients during the public health emergency. Thank you.
Thank you for joining us. I'm really looking forward to listening. Can we kick off with the situation before you implemented telehealth, the conditions under which you were having to operate, the health concerns of the population that you serve, the regulatory or policy or the rules around the use of telehealth, all of those situations that even caused the problem or caused the challenge?
Sure. So the American Indian and the Alaska Native population have some disparities. They also have health concerns. Some of the leading causes of death or disease, heart disease, cancer, accidents, diabetes, mellitus. There's a high prevalence of mental health issues and suicide, obesity, substance abuse, sudden infant death syndrome, teenage pregnancy, liver disease, and hepatitis. So as you can see, there are these disparities. There are these high prevalence of health concerns that we want to make sure during this public health emergency and after and before that we provide care and reach out to this population to support population health and the patient. Thank you.
And the rules or the conditions of access, the limitations that you had or the constraints around how tele can be used in healthcare?
Sure. So with telehealth, on March 27th of 2020, we advised our healthcare providers that they could use, with the waivers and the flexibilities, that they could use non-public facing audio or video communication technologies to augment their clinical care. As we have patients who live in very rural and remote areas, and we wanted to be able to support them so that they would not have to drive. Some of them could drive 3 hours to a healthcare facility. We did recognize that it needed to be non-public facing. IHS has a telehealth solution that was already in place, and we wanted the healthcare providers to know that they could use this technology to reach out to the patient, that if a patient needs care and you don't want to bring them into the facility, that you could utilize telehealth. And again, we did need to recognize that there are data charges. We need to continue with the patient verbally consenting to this type of modality. And we recognize that we don't store records within the telehealth solution. Thank you.
Thank you. That's really interesting. So we heard about a population of, I think you said 2.6 million people, and they're remote and they're in different types of locations. And then we also heard about the conditions around the modality that you were going to access them. Tell us about the solution then, the implementation, the solution, the components of the solution. What are the pieces that you pulled together to be able to deliver telehealth? Whether they were technology components, but maybe even the collaborations and the partnerships that you worked with to deliver.
Yeah, so on April 8th, prior to April 8th, we had probably about 1 month to get ready. So as I shared, we had a telehealth solution, and I placed a disclaimer that I'm not supporting one solution over the other, or no vested interest, but we had a telehealth solution in place. And we needed to expand it rapidly to get it out to all healthcare providers. So we formed a clinical technical teams to determine what it would be needed. We also reached out to other agencies' best practice. So when you think about the VA, that they have Veterans Administration, they have a huge telehealth program, and how are they utilizing it? We also reached out to other, the FCC and other agencies, and I'll share more about that with partnerships. But on April 8th, we expanded telehealth agency-wide so that any healthcare provider could offer telehealth services to their patients. And that's so important because, as you note, we're in rural areas. We have a very big digital divide, and the key is that no door should not go open. So if a patient is asking for support and care, we need to be able to provide that care. It's not just only patient care, but when you're having this public health emergency, you have provider to provider consultation and care. So when you think about collaboration, not with other agencies, but within your own, provider to provider, you might have an external referral to reach out to. You might need with emergency care, as patients were requiring intensive care support, and patients might need to be transferred, that you have that resource and that you can utilize telehealth. So we adjusted to the increased demands of telehealth services within IHS, and we needed to recognize that it was important to look at how we're using telehealth. And I'll talk more about that with our metrics and if it's meeting their needs, and I'll share more about that.
It's true. I was starting to think to ask, and how is it going, and how do you know how it's going? And it is through the metrics and the survey data and all of the measurable things that you're doing. Would you like to tell us more about that?
Sure. And I just want to share that when we expanded telehealth, we piloted it first. We made sure people could utilize it. We changed things based on input, and we formed this IHS COVID-19 telehealth leadership team. So we rolled out April 8th of 2020. We offered many webinars pre and post how to utilize telehealth, how to support that. We have a very big presence with our Telebehavioral Health Center of Excellence that was already in existence. And we created a listserv so people could share information and share what's working, what's not, as well as developing a toolkit. You saw a lot of toolkits come out with telehealth in the beginning, and ours was related to Indian Health Service. So if you were considering creating a telehealth program or offering telehealth, these were resources that were more specific, and we have our website as well. And before I kind of go through the metrics, to recognize that our electronic health record is the resource and patient management system. And you have to also recognize how providers are coding or documenting their telehealth, because that also has an impact if it's workload reportable or not. And their electronic health record, the way things are coded, has an impact on even the budget. So we wanted to make sure that we had standardization, documentation standardization, and that's still ongoing. And we also then wanted to look at the telehealth experience. How can you look at success? So we developed a survey, and we, in November of 2020, we sent out the survey and we asked a couple questions. And you can see here from the slide who our provider types were, mainly physicians. We had many different healthcare professionals. And as you can see, nurse practitioners, counselors, physician assistant, and others were the top 5. What we asked during that survey, some of the questions, and this is not everything, but to identify how many in the last 2 weeks, how much time was devoted to telehealth. And as you could see, this was in November, but a small amount, so greater than 60%. That was one of the majorities that we saw with responding to telehealth. And one thing to note is that 63% of the responders addressed that. So in the time that they devoted, it was 63% of respondents spent about less than 40% of their clinical time providing telehealth. The other thing to share is what telehealth services would be valued. So we offered telehealth, but what other services that you might need to have as consultation. And again, this is during the public health emergency, COVID-19, and behavioral health and specialty care were recognized. So we do offer different types of services besides, emergency care. We offer behavioral health, and to see the responses so that we can help reach out to our clinicians and see how we can help with their needs.
That's really interesting that even, especially in the middle of a public pandemic of the COVID-19, you still have demand for telehealth services that are in behavioral health, specialty care, primary care, chronic illness. People were, rightly so, people were still looking after their overall health rather than only focused on COVID. And that's really powerful. And that they can look at all of these services from telehealth.
Yes, and if you look at the valued infrastructure, that's one of the things also to recognize is that we are in rural areas. There is lack of bandwidth, there is lack of internet connectivity. We have patients who may not even have smartphones. And we did find that out. So people might have had to borrow somebody else's phone, might need to go to a certain area to reach out to their clinician or somebody's house or a chapter house. And I'll talk about that. But the recognition of the platform. So with this evaluation, the valued infrastructure of having a platform that can support telehealth. And one thing that we found, and I'll show you that in our metrics, is a lot of our telehealth care and support is audio or telephonic only. This just talks more about the technology improvements. So that kind of segues into infrastructure, equipment, and platform to build the infrastructure. And this will help us this helped us, seeing their responses helped us to determine that we also need to look for another telehealth solution that's scalable. We wanted to look at something that's cloud-based, and I will share that as well. And then just the technologies for improvement. With the survey, there was a quantitative aspect and a qualitative aspect. So, you hear of equipment, hardware, software, and remote monitoring equipment, challenges with the platform meeting the need, and having staff, recognizing dedicated staff for telehealth, to help schedule, to help get them in the room, to help the healthcare provider, and IT support. So infrastructure, again, big thing, digital divide, and lack of bandwidth. And these are some of our other improvements that would be helpful. This just recognizes overall, if you looked at that it's a vital, that improved access, improved health of patients, and patients seem satisfied, that all the healthcare providers either agreed or strongly agreed. And it's so important that the collaboration is there with other agencies, with the patients, with our tribal and urban partners, so that we can provide excellent quality care.
That's really powerful in terms of the collaboration. It is through that whole ecosystem almost that care is delivered to these patients and these people. Tell us within metrics how it's going on utilization, utilization, the encounters, how have they increased or decreased, and how they fluctuated. That's really powerful, especially for the duration during the period that of the metrics that you're reporting. Let's not forget came through a COVID-19, but also of this type of patient, how they're located remotely, and all the challenges of the bandwidth. So it's really interesting to see how they took up the service.
Sure. So beginning in March, and I'm going to share this slide. Beginning in March of 2020, IHS facilities rapidly increased virtual care services from pre-COVID averages of under 1,300 per month to peaks of over 40,000 in last year in June and July of 2020. And based on coding data from the Indian Health Service electronic health record, we were able to provide metrics. So as you can see, the peaks from last year, and as we continue to look at our metrics, you can see the decrease of the use of telehealth. When you look at the colors, what you're finding is that the IHS facilities use telephone only most frequently, and that is about 80%. So this is all based on our HCPCS codes, CPT codes, and modifiers. And what the reason for utilizing telehealth, as noted, is related to audio only, is related to some of the constraints or challenges that we do have. And I will share some more data with you, but the most frequent metrics that we just received is that 8% of all visits in the federal space or encounters was telehealth in August. And that was all visits was 185,000 visits, and roughly telehealth was 14,698. We also like to share some of the tribal utilization of telehealth. And what we're seeing is that for tribal use of telehealth, there's more video use. And some tribal communities have different commercial off-the-shelf electronic health records that might relate to different video use. But what we're finding is that the tribal facilities use telephone only about 50%, and that the facilities use video about 48% to conduct telehealth service. And as I noted before, again, you're seeing the decreased use in telehealth. And it would be interesting to see with the Delta variant if that increases. So we're looking at the metrics closely to see how telehealth being utilized. This is just more tribal encounters for telehealth. And we look at it through service categories. We look at it with workload reporting and clinic stop codes. And 5% of all visits use telehealth in August. When I compare the two, and this is the comparison of telehealth encounters, federal and tribal, it's roughly that what you're seeing is in terms of video use, that it's about double. So tribal facilities utilize about double video use when they're meeting with their patients.
That's really striking, that graph. You can see the shape of the graph is the same, but then, as you say, tribal uses double video than federal. Mm-hmm. Is there a way of working out why this is the case? Is it the bandwidth? Is it the location being more rural? Are there any reasons that you can?
So that's a great question. And, as I shared, some of the tribal partners utilize commercial off-the-shelf. And with public health emergency, we are allowing other solutions to be utilized, like Facebook or FaceTime and Facebook Messenger. So when the coding is done, we're looking at that, but this helps us to determine that if we get another telehealth solution that's scalable, will our video numbers go up? And I'll share the award and the acquisition in a minute.
That's really interesting. So on the final piece on community strategies, all the collaboration with partners, tell us more about how that future is looking like, your plans around any upgrades, acquisitions, improvements, additions,
Sure.
and your plans around the future of collaboration.
Sure. So it is vital that there is collaboration, federal, tribal, and urban partners, and then agencies, and also, real world, what is taking place. You're seeing now a lot more studies being done, best practices for telehealth. When we looked at community strategies, one thing that we look at is, we are rural in some of our facilities, and how can we get devices into the hands of our patients? We reached out to the FCC, Federal Communications Commission, the Department of Commerce, and that is the National Telecommunication and Information Administration, or NTIA, and the VA. So the collaboration was there to meet and see what they're doing. With the NTIA, over the past year, they had over $1 billion to support telehealth programs and grants for tribal programs. With the FCC, they have the Lifeline program. So that also helps provide funds. So when you have patients who might not have a lot of resources, funding to help either with a smartphone or to help with, your services is huge. And it's vital. So we did meet recently in August with the VA, and they shared that they have a telepresenter certificate program that they're partnered with the University of Florida, and it's free for those who would like to take it. So these are some of the strategies that we're looking at. And again, we do recognize that it is a challenge when you are dealing with rural areas. So when the pandemic first hit and patients needed to go to the facility, the facilities might have internet out in the parking lot with tablets that the patient could utilize. And so it's being innovative in your thinking, looking at chapter houses. Maybe you could provide internet in these chapter houses, and how you can collaborate with those in the community, with your other agencies, and with our other tribal programs. This just talks about the acquisition that we awarded. So we went through a whole acquisition process, performed market research on what's out there. We developed our requirements. We had a clinical and a technical team to look at the different vendors and the proposals. The contract was awarded on July 8th. AA Ring MD Joint Ventures LLC was the vendor who was selected, and it's going to take about 6 to 8 months to complete the authorization to operate the ATO process. And one last thing to share is, so our evaluation, as noted, recognized the need for infrastructure, looking at platforms, things like that. So Cisco Meeting is the telehealth solution that we utilize from the get-go, and it's now being upgraded to WebEx. So we are in the process right now of a phased approach implementation with pilot testing, a small group of users, then facilities, and we hope to go live by the end of October beginning of October, with Cisco Meeting sunsetting in the end of October. The last thing to share too is about the notice of proposed rulemaking. So CMS officially released the proposed rule in July, and the time to provide comments was by September 13th. But I always put this in here because it's important to know these rules. As you can see, when we talk about collaboration, there was an HHS telehealth group that would meet to look at what sort of things could we suggest keeping post public health emergency, post pandemic. And this rule addresses some of those, the audio only interaction. They recognize the need to require in-person non-telehealth services to be provided by the physician. They provide some information about that. I did include that in the presentation, the link to the notice of proposed rulemaking. But to realize that everybody is finding audio only has been positive alternative to providing telehealth when you have areas that cannot do video. So these are some of the things that have been suggested.
Let me see if I get that right. So the proposed rulemaking is proposing to limit the use of audio only, but that's going to be a challenge for the areas with low bandwidth because they do require audio only. Is that where we are?
So that's so it'll be interesting to see what the final rule states, but to recognize that at least audio only will be recognized as one modality. It'll be interesting to see who will be allowed to use audio only.
Okay.
Yeah, because one thing that I look at the rule, it says to allow certain services added to the Medicare telehealth list to remain on the list that ends December 31st, 2023. And it also expand access to mental health services by allowing patients in any geographical location and in their home to access telehealth services for diagnostic evaluation and treatment for mental health disorders, allow for audio-only communication technologies to be used when patients are in their home when receiving telemental health service. So like I shared, it'll be interesting to see who will be allowed to use audio only when the final rule is published. One thing to share, and to put a plug out, the Indian Health Service has a listserv. Anybody can join this listserv, and we also have our website if you would like to contact us. And this is information about our IHS award for the telehealth contract. We did recognize the increased demand for telehealth services, and to complement the current telehealth platform, we are implementing another platform that is going to be cloud-based and scalable.
That's amazing. Thank you, Susy Postal, the Health Informatics the Health Informatics Officer at the Indian Health Service. Thank you for also everybody who's helping with the IHS telehealth initiative. From us at the Partners in Digital Health, thank you so much, and good luck for all the future endeavors you described.
Thank you, and thank you for the opportunity to share the great work taking place. And I truly am appreciative of the collaboration within IHS and external to support patient care.
Hello, everybody. Good morning, good afternoon, and good evening, wherever you are. You are joining the Converge to Accelerate conference, ConV2X, the 2021 edition. On behalf of the partners in digital health, I thank you for joining us today. This is going to be a very interesting session with the title, How Health Plan Providers and Telehealth Partnerships Advance Care and Scaled Adoption. At this point, let me welcome Dr. Scott Rissmiller, MD. He's an Executive Vice President and the Chief Physician Executive at Atrium Health, speaking to us from Charlotte, North Carolina. Hello, Dr. Scott.
Good morning, good afternoon, good evening. Thank you. Good to be here.
And welcome to you. Thank you for joining us, and thank you for joining Converge to Accelerate. We'd like to listen to you, Dr. Scott, about the Atrium Health Virtual Edge. Who are you, and who are you becoming at Atrium Health Virtual Edge?
Sure, and thank you. And I really appreciate the opportunity to speak and to share our experience. It's been quite a journey, and the best is yet to come, we firmly believe. So next slide, please. Just a little bit about who we are at Atrium Health. Next slide. So we are a large integrated healthcare delivery system. We are over 70,000 employees, approximately 40 or so hospitals across the Southeast, mostly North Carolina, South Carolina, and Georgia. About 12.4 billion in revenue and growing quickly across the Southeast. So we have aspirations to continue to grow and spread our mission, which is truly to provide health, hope, and healing to all, regardless of ability to pay and what have you. And I will tell you that the telehealth journey has greatly advanced our ability to live up to our mission. Next slide. So we have been on this journey for about a decade now, and we really believe that the key is not just technology. And I think that's a given, and lots have figured that out, some the hard way by thinking that the cool, snappy technology tool is going to solve all the world's problems. And in healthcare, it's extremely complicated, as we have all come to find out. We have focused really in 4 areas: the virtual clinical teams, which sounds straightforward, but that is a huge culture shift for a lot of our clinicians, and for our patients as well. The clinical and culture and workflow, the telemedicine platform, which is user-friendly on both sides, both from the provider standpoint as well as from the patient standpoint. And then undergirding all of this is a rigorous data algorithms and reporting for that continuous improvement. We pride ourselves as a learning organization, and it really is that data and the underlying it that allows us to continually improve our process and meet our patients' needs. Next slide. So we believe the demand drivers for telehealth sort of break into 3 areas or buckets. And man, we have seen this accelerate over the past year and a half with the pandemic. So really the 3 that we break it into for demand is the policy and advocacy, the technology and innovation, and consumer demand. I'll hit each one just quickly. Policy and advocacy, that is where we have seen just incredible progress in regard through the pandemic. You know, you always try and find the silver lining in difficult times, and certainly the pandemic has been something that none of us would have wanted, nor do we want it to continue. I'm ready for it to go away. Personally, I think we all are. But we've had incredible progress on the policy and advocacy front, especially in regards to regulation and legislation in the United States, where through the emergency waivers, we have been able to really grow our telehealth footprint. And we'll show you our advancements over the past year and a half. But that has been significant, and I think really sets the framework or the groundwork, if you will, for accelerated progress from this point forward, if those regulation allowances continue. And I think that is still in question. Technology and innovation, we have been able to do things over this past year and a half that we've been talking about for a decade, but didn't believe was maybe ready for prime time, if you will. And it's really been through the ingenuity of our clinicians that have really advanced the user case for telehealth. And fortunately, we've had great partners along the way that have provided the digital and innovation that we have needed to keep up with the care models that our clinicians have been developing over the past year and a half. And then consumer demand. It was sort of a nice to have, if you will, prior to the pandemic, and it very quickly became a must have if we were going to be able to continue to serve our patient population. And the great thing is we knew before from our data, before the pandemic, that if patients gave telehealth a try, they actually loved it and came back. But it was just getting them to do that first, press the button and do the visit. And so the pandemic sort of forced our communities and our patients to do that, and they love it, and they've come back. And now we find ourselves in a good position where going forward, patients don't want us to go back to pre-pandemic models of care. They love the access that comes from telehealth, and to be honest with you, so do our clinicians. So the consumer demand is driving a lot of what we do now. Next slide. And then on value creation, this is just the buckets that how we look at it from an integrated healthcare system. The first is really access. And when, certainly when you think of access, you think of, I I have something that I need to get in quickly. Let me push a button and get access to that care. But where it is really shown or shined, if you will, is in our underserved areas, whether it be rural or in our urban areas. We had a no-show rate in our underserved clinic, our urban clinics in Charlotte, North Carolina, of about 26, 27%, meaning 1 out of every 4 patients prior to the pandemic was not able to make their appointment. And that was primarily due to transportation issues. And we switched to virtual during the pandemic, and that no-show rate dropped to 7 or 8%. And we've been able to maintain that. So with that comes improved outcomes, which is what we're about, caring for our communities. So the access is huge value creation. Delivering the higher acuity locally, we are able to keep very sick patients in their rural hospitals by bringing specialty care to them. And track and engage patients, partners, and providers. Obviously, we've made great relationships in our communities as well with other partners to help do this telehealth. Reduce transfers capacity, that has been a major issue through COVID, to allow us to be able to reserve beds for the sickest at our quaternary facilities, and then spread infrastructure across our organization, cost across our organization, and improve efficiency of care. So this has been something that when you're starting up, it's always very expensive, but as you can grow it and scale it, there's those economies of scale that have really allowed us to expand quickly. So that's a little bit about our journey and who we are, and would love to keep going from here.
Yes, sir. Thank you for that. Dr. Scott, would you tell us more about the journey up till now, the years that have passed that have allowed you to be in this position?
Absolutely. Thank you, Joe. So we've been about a decade ago, my predecessor as the chief physician executive, Roger Ray, asked a group of physician leaders, a decade from now, if we were to fast forward, what is that one thing that if we do not invest in now, we will wish we had? And the resounding answer was virtual medicine telehealth. And so we started our journey in telehealth about 12 years ago. And at that time, it was pure cost and investment. And it was started by people raising their hand, hey, I got a great idea. And then over the years has turned into an integrated program of care for our patients. And again, we view telehealth as care, nothing special. It's just another tool in the toolbox so patients can receive the care they need. And we really focus it around the patient, and we look across the entire continuum. And one of my concerns with telehealth, I do believe, if done in a siloed manner, has the risk of siloing care or fragmenting care further. So I do believe delivering virtual care or telehealth in the setting of an integrated delivery system is very important to keep that continuity. So we partner with the community through school clinics, employer clinics, primary and specialty care. Obviously, we have a great program where we integrate behavioral health into our primary care office virtually, and I'll speak to that in a second. Emergency care, telestroke, telepsychiatry, telehospitalists, inpatient. You can see virtual critical care, tele-ID, where we've been able to, especially through the pandemic, keep patients at home in their high acuity patients home in their local community hospitals. Post-acute through patient observation, telehospitalists, again, coming into the post-acute setting, and then into the patient's home. We developed a Atrium Health Hospital at Home, which I'll touch on, which in 2020, we were able to care for over 50,000 patients with COVID in the comfort of their home with great outcomes and very high acuity patients, which we'll touch on in just a moment. So next slide. So a little bit about a few of these programs and thinking about the partnerships. We are able to, in one of our rural towns, Shelby, North Carolina, we are able to partner with the local government and local public school system and pilot it, and now it's really taken off. A virtual in-school care program where, you know, in current state, if your child gets sick in elementary school, you get that call, you have to leave work, you have to try and get them to a doctor's appointment, and the day is pretty much shot. So we partnered with our local public schools in this rural setting, and it provided virtual care pediatricians to the school. So now the school nurse can beam in immediately with a pediatrician, and we are able to get that patient either back into the classroom quickly after an evaluation, or we're able to call in the prescriptions right away, have them ready, so when the parent picks the child up, they have the prescription and everything else, decreasing time to treatment and those type of things. What we've seen is significant improvement in access. 20% of these patients did not have a doctor, so they would have struggled just finding access alone. Improvement in management of chronic diseases, reduction by a third of early dismissal. So a third of these students were able to go back to class that day, and then reduction, over 50% reduction in inappropriate ED visits as we monitor this. So great partnership with local schools and serving our rural communities. So next slide. So virtual behavioral health, this is another area where we have invested significantly in incredible innovation of our teams. We all know that behavioral health is a national shortage, and especially through the pandemic, even more so, is a national emergency where access to behavioral health is very, very limited. So what we did was we were able to embed behavioral health specialists into the primary care office. And the way it works is when a patient goes to their primary care physician, they fill out a form that screens for anxiety, depression, and other mental health issues, the PHQ-9. This is captured within the EMR, but also is given to the primary care physician as they are going in to see the patient. If there's something on it that flags that this patient is at risk and needs help, following the primary care appointment, they are then immediately connected virtually to a behavioral health physician or PA or nurse practitioner who is able to diagnose and start treatment immediately. And then they are registered within our registry and have ongoing care from that point on with our behavioral health team through the primary care physician. So what this does is immediately provides that access and starts treatment immediately, and then provides for the follow-up. The results have been significant, and we have data underpinning all of this. But really, you see improvement in their mental health issues, but you also see improvement in clinical outcomes. You see a lowering of their hemoglobin A1Cs if they're diabetics, improvement in their cholesterols, weight, et cetera. Because of when we're in a better place mentally, we're more apt to adhere to the care plan that has been prescribed. We've seen decrease in inpatient visits, emergency visits, et cetera, and lower cost of care through this. We have published this. We have the data underpinning all of this, and it's just been a great success story. And we're currently scaling this through all of our 100+ primary care offices. So next slide.
That's just amazing. Dr. Scott, can you talk to us about scaling for the future, how the acceleration through the pandemic and beyond?
Sure. So as I said, you always try and find the silver lining in every challenge, and certainly the pandemic has been a challenge. But there's been so many great stories that have come through it, not just with us. I hear it across the country. So next slide. So what really enabled us, two things enabled us to truly accelerate. One was the ingenuity of our clinicians. And they came together and really went to work at going, okay, we're not able to bring patients into the office. How can we flip this switch virtually quickly in a way that allows our patients to receive the care they need and allows us to be efficient? And we are able to pivot very quickly, as you can see by the growth in visits down at the bottom, April, May, significant increase in both ambulatory encounters and visits. And this was also fueled by the public health emergency, which allowed for several things. It allowed for across state licensing. We're at Charlotte, North Carolina, right on the border of South Carolina, and we also are down in Georgia. So to have that waiver in regards to state licensing was huge. As well as the flexibility around site of service has been a significant accelerator. And then also just the coverage and payment parity. This is something that requires a fair amount of investment to have, one, the infrastructure in place, but also the ongoing ability to offer it to our patients, and to be able to receive reimbursement for that to cover our costs and investment at that time allowed us to truly accelerate. And this is where we are advocating at the state and local level and the federal level to ensure that these things that enabled us through the pandemic, through the public health emergency waivers, stay in place to allow us to continue to accelerate, because we think this is crucial to the ongoing care of our patients, especially in underserved and areas such as rural and urban locations. So on the flip side of this, what this also allowed was patients to access us in a much more consumer-friendly way and to receive the care that they needed, and really sort of allowed us to build the trust with the patients. And underpinning all of this, we are a learning organization. We have incredible data sources that show the improvement in care, the patient experience around virtual. It continually gets very, very high marks from a patient experience standpoint. So it has been a win-win, but it really was two things. It was three: the ingenuity of our clinicians developing these models; two, the relaxing, if you will, of the regulations around it that allowed for acceleration cross state, as well as parity from a coverage and payment standpoint; and then three, the acceptance of our patients, winning them over through the care model. Next slide. So you saw from the slide, but we saw, and lots of people saw this, it's crazy numbers, right? It's 6,000%. I'm not even sure how that translates, but big growth in regards to virtual visits. And we were doing a lot prior to 2020 as well. The development of the hospital at home, which I'll touch on in just a quick second, really was significant for Atrium Health, and I'll speak to that in a minute. Inpatient virtual care, hospitals we have one hospitalist program which we grew ourselves at Atrium Health that covers all of our 30+ hospitals, and they were able to flex virtually rather than having to drive to the different hospitals to cover. If there was a surge at one hospital, we were able to admit patients, et cetera, virtually, really expanding the efficiency of that team through virtual measures. And then we're growing. Recently have acquired Madison Health in Macon, Georgia, and most recently Floyd Healthcare System in Rome, Georgia. And we are actively, aggressively expanding our virtual offerings there. Next slide. So hospital home, this was started last March or so when obviously the pandemic hit, and we're faced with a couple things: PPE shortage, as well as capacity constraints in our hospitals. And our clinicians came together, and in a matter of just a couple weeks, with partnering with IAS, our IAS team, our HR team, et cetera, we are able to develop this hospital home. And it's 2 floors. And just real quick, there's an observation floor, and then there's more of an acute floor. We were able to partner with some of our technology partners to get basically a hospital at home kit that would go home with the patients. If you were diagnosed with COVID, you were sent home with a blood pressure monitor, as well as a pulse ox machine. We're able then to link that through an app that we developed in your phone that immediately connected to your EHR and to our care team. So we had a team of nurses and physicians who are able to monitor thousands of patients at once in real time through this app. On the observation floor, we would just check in with them each day, and they would do their blood pressure and oxygen levels and temperature throughout the day, and we were able to monitor those. On the second floor, the more acute floor, we would actually send community paramedicine into the home on a daily basis to do in-house assessments, as well as continued virtual monitoring. We are one of the few healthcare systems, or the earliest healthcare systems, to do IV remdesivir at home. To receive IV remdesivir, you have to be on home oxygen therapy in that. So these are sick patients who would have been in our hospital. So this freed up capacity in our facilities, and the experience for our patients was amazing. They love this program, and that we are now in the process of transitioning away from COVID patients now into more chronic patients, heart failure, post-stroke, post any medical issue in the hospital, allowing for earlier discharges, lower cost, et cetera. So really exciting program that we have developed and are scaling. Next slide. And again, underpinning this is a partnership with CMS at this time. They have a program, a waiver, which they've invited a small number of hospitals and work systems, and we're one of them, to really look at exploring hospital at home as an ongoing viable solution for patients who can be cared for at home, but that are higher acuity and normally would be in the hospital. You can see the criteria here. What this allows for too is payment parity around this. So we are being reimbursed as if it's an acute facility, and we have to meet all the same criteria. And we're currently doing so as if the patient was in the hospital. So this is really exciting. We're super excited to see where this goes. And it allows us to be able to continue to develop this. I truly believe the future of healthcare is at home. That's where we all want to be. And I think we're on our way to doing it. And partnerships like this with CMS is key to achieving that. And then next slide. So this is how we sort of view things. You know, organizationally, we think we have over the past decade built out these areas of strength, engagement, buy-in from our patients as well as our clinicians, the clinical and technical expertise, dozens and dozens of different models. Our clinicians are bought in. We've proven we can do it, and we have that reputation. We have the resources and structures, and also partnerships are developing and are accelerating. External factors, certainly. The market is looking for this now. We have a sicker population that I think telehealth virtual care is poised to really serve. And then payment model changes, partnerships with CMS, our state and local governments, as well as with commercial payers, et cetera. Lots of opportunity here. And this is where I think our biggest risk and opportunity is. If we go back to our COVID regulations and policies, I'm afraid we're going to see telehealth start to decrease again. But I'm optimistic in what we're seeing in regards to our partnerships and the conversations we're having, because I do believe that this is the future and our patients want it and demand it, and as they should. So next slide. So that is all. That's a quick overview of who we are and our journey over the past decade and how we're accelerating. Again, it cannot be done without partnerships from technology partners as well as state, local, and federal government. The biggest things we need are continued the things that we are allowed to do through the pandemic to continue, so we can continue to invest and grow what I believe is the future of healthcare, and is poised to improve access to those who need it most, the underserved and others, and to lower the cost of care for healthcare. So, Joe, I appreciate the opportunity to speak.
Thank you so much. Deeply interesting and very, very exciting future as well. Thank you so much, Dr. Scott Rissmiller, the Chief Physician Executive at Atrium Health. Thank you so much for speaking to us today.
It's my pleasure, and thank you for having me.